In this block, we are going to talk about the electrolyte disturbance. First, we start with hyperkalemia, when the serum potassium concentration is higher than 5.5. The extracellular potassium concentration will influence the resting membrane potential. Based on the Nernst equation, the ratio of the extracellular potassium and the intracellular potassium will alter the resting membrane potential. The primary affected cells are of the nervous system, the skeletal muscles, and the cardiac muscle cells. Generally speaking, if the potassium concentration increases, that will cause hypopolarization. That is going to increase the excitability of the cells. When the membrane potential getting closer to the threshold, it's much higher the chance that it can be reached and can induce an action potential. However, when we decrease the potassium concentration, that will cause hyperpolarization, so the resting membrane potential is getting lower than normally. This is why it's more difficult to activate the cells, because we are getting far from the threshold. This is why the excitability will decrease. This becomes more complex. In the heart, when we do have an increase of extracellular potassium concentration, the excitability will increase first. So tachycardia, premature beat formation will increase, because the voltage-gated sodium channels open when we are getting closer to the threshold. However, when we are getting close to the threshold, these voltage-gated sodium channels are closed, so it will influence the sodium influx. So the sodium influx is be slower and the excitability will decreases. The repolarization abnormality first, it will be presented as a T wave. Let's be peaked the T wave. The conduction abnormality that will influence the P wave and the QRS complex. Let's be the P wave be wide and flat, while the PR interval is getting prolonged, and the QRS be wider. The impulse formation abnormality presented as bradycardia.
In experimental models, ECG changes produced by hyperkalemia follow a typical pattern that correlates with serum potassium levels. Peaked T wave, P wave widens and flattens, PR interval lengthens, QRS complex widens and eventually blends with T wave. In practice, however, this pattern is present only in a fraction of hyperkalemia patients and does not always correlate with potassium levels. This makes diagnosis on the basis of ECG alone very difficult. Given the dangerous nature of acute hyperkalemia, it must be suspected in any patient having new bradycardia or conduction block, especially in those with renal problems.
Summarize the different concentration effect on the ECG sign. When we do have a mild increase of the potassium concentration, mostly the peaked T wave, the symmetrically peaked T wave, is the only things that we can see. After the PQ elongation and the P flattening be another one. When we do have a moderate increase of the potassium, so ranging from 6.5 to 8 millimole per liter, the P wave disappears. QRS is widening, the ST segment is elevated, and a lot of ectopic beats, escape rhythm, can develop. In severe case, when the potassium concentration be higher than 8 millimole per liter, the QRS progressively widening, and it looks like as a sinus wave, the QRS be a sinus wave. The initial one be the QRS complex and the next one is the T wave. But ventricular fibrillation, asystolia, axis deviation, bundle branch blocks and hemiblocks will develop very frequently. This tracing shows a sign of hyperkalemia. As you do see, this is rhythmic heartbeats. We do have tachycardia because this rhythmic heartbeats comes earlier than 3 big squares. We do have sinus P wave because positive in lead number 2 and negative in AVR. And every P followed by QRS complex. The PR interval is normal in this situation. The QRS is narrow and the axis is normal. The axis is around 60 degrees as you see here because the equiphasic QRS complex can be seen in AVL. By looking at the QRS complex, next we are going for the pathological Q wave. Here in V1, V2, V3 we can see it, and the R propagation is very slow because normally the transition occurs between V3 and V4. However, here we do have between V4 and V5. So that's be a clockwise rotation of the heart. Looking at the STT, we do see ST elevation and a peaked T wave, especially in V2, V3, V4 in the precordial leads, very tall and symmetric T wave. So generally, this is the sign of a. In the next, we see that stereorhythmic and very wide bizarre QRS complex can be seen. The P wave disappeared. However, this rhythmic, it looks like it's a ventricle rhythm that we do have. However, this is not ventricle, that's a sinus one, but due to the increased potassium concentration, the QRS is widened. Further increase in the potassium concentration looks like we do have a sinus wave that's representing the depolarization, repolarization, depolarization, repolarization, all right? And tachycardia occurred in this ECG tracing.